why we're talking about health, is because the President's advisor on health financing is our next guest. Dr. Daniel Mwai is in the studio. Dr. Harry, good morning.
Good morning.
Good to have you back in the Situation Room in the hot seat.
Thank you very much. It's my pleasure to be back.
The last time you were here, it was before the laws had been passed on now giving us that roadmap to UHC. We have to talk about now all those things and what has happened since then, and what we now have called the Social Health Authority that is supposed to be driving us towards nirvana. You'll tell us how that journey is going, but CT will welcome you with the day's proverb. This week, the proverbs are from?
The Republic of Angola. What has been wet by rain cannot be wet by the fog.
What has been wet by rain cannot be wet by the fog. Dr. Mwai, what's your interpretation of this proverb?
I would begin from thinking that rain has more intensity than fog. So if, an issue has partially been, solved or provided a solution for, you need a higher, you need to go up. You cannot go from rain to fog. You cannot remove from rain to rain. So I would think that I would be up. And from where I look at it from, we have had our institution that have been trying to wet. We can only go up. And more so within the healthcare financing architecture. Thank you.
So basically what we are saying here is if we look at SHA and NHIF,
Yes.
SHA is rain, NHIF is fog. So we're moving from fog to rain. So we can be properly wet.
Correct.
I wonder.
Wow.
His interpretation is actually
very
appropriate.
rich.
It's appropriate because he's given it context. And it's good context. And since he's given it context, I have to ask, why do you say that? What are the reasons that you have for claiming that NHIF is fog, SHA, rain?
Thank you very much. I think I first want to highlight that when you look at the Social Health Authority, in there is a fund called the Social Health Insurance Fund, which is a complete upgrade of the National Hospital Insurance Fund, which became National Health Insurance Fund. So then you are moving from the fog, which we have, and fog also provides some wetness. We cannot say that it doesn't, but rain provide more. So in moving from the NHIF to SHA, SHA has more by far, because SHIF would actually be an upgrade of NHIF. Thank you.
And then SHA now has the SHIF, it has the Primary Healthcare Fund, it has the Emergency Critical and
Chronic
Illness Fund.
Yes. 3 into 1.
See, it is beating you from all sides, this rain on that side. However, Dr. Harry, since the President launched our journey towards universal health coverage last year in Kericho, we've just been watching and hearing things unfolding. And the country was prepared to move into this transition at the beginning of this month. And then we hear, no, this has been pushed a little bit because, there are some things that are not aligned, this and the other. What is it that's not aligned?
Thank you very much, Latif. I think two things that I want to highlight. One is that this agenda on healthcare financing has not begun now. It's actually not even this government agenda, so to speak, in terms of originality. It started a long time ago with the declarations of through the WHO on the desire for countries to move towards universal health coverage. And we have tried several things, and you can the known one is the Giro Bill of around, I think, 2003, if I'm not wrong.
Yeah.
And the Giro Bill then was trying to provide a legal framework to actually anchor this, financing architecture in a way that it is possible to get accountability. It's possible to drive the financing in a way that it accounts for a greater good for all. Now, from that, what has happened is that good things should take time to plan and to execute. More so if you have failed several times. And people would wonder, why has it taken long? One, it has taken long because we didn't have legal framework, which enables not only for us to push the light financing architecture, but also bring accountability to the same, and also stop, kind of inefficiencies that arise from the system that we have been learning under the fog system. So with that, it's what has made us take long. Now, when you look at the process of legislature, and also after the passing of the laws, then comes the regulations, which prescribes how will this be done. Now, the how also requires it to be organized in a way that you need to move to public participation, develop all those until you finalize with them. Now, that is what has been happening. On the other hand, there is money that is needed, because when we go to the model, you see this is not just a social health insurance issue or an insurance issue like in the past where we lost it, because at some point we almost thought healthcare financing is a social insurance issue only, and there is no other approach that is useful, and therefore UHC was reduced into financing. But UHC is bigger than financing, as you have put in your opening remarks, because there is access, there is quality, and there is also the issues of social protection, which are actually important in terms of people getting into poverty. Getting into poverty because of expenditure. So ideally, that is the architecture that we have been creating. You need to have a good system. The system needs to be robust. You need to allocate resources for the same. You need to look at how do you transition so that services are not disrupted. You need to see, to reanalyze each of the issues that had been raised within the panel of experts that developed the report on how to, on NHIF we want. Now, if you look at each of those, there is no principle which is aligned to WHO that we have not followed. So that's a process. Okay. And it's a project that this has taken a little bit long, but I think we have started with the registration, and that is a first step into the first fund.
So, Dr. Ari, from legislation, we saw the 4 bills that went through Parliament, they were passed, and then there was the launch, because now we say that is the moment in which the President says, so now with the legislation in place, now we move towards implementation and realization. How long, ideally, should it have taken, or should we have been looking at to actually get to a level where we can say we are good to go? All those things that you're saying, the preparations, drafting the regulations, taking them through public participation, getting people to understand that these are the regulations, this is what it means, getting the other stakeholders, the service providers to understand and get on board, all the doctors and medical professionals to understand and get on board, getting the funds aligned and the budgetary allocations then set aside. You need a budget for the primary healthcare fund. You need a budget for the other emergency and critical illnesses fund. All those need to be put into place and factored in. You need to bring in the MPs on board so that they can approve the appropriation of these funds into it. How long should it have taken? Was it realistic for us to say that 8 months was good enough for us to go?
I would think that it would have taken probably 8 to 10, 12 months, so to speak. But we felt that we can, put all our hands together and push this. Have we missed the target? Yes, we have a little. But when you start, you move into implementation, you also discover that there are things that take longer. For instance, the long discussions with the providers. Because when you develop the benefit package, you need to take it to the public. After public, you come to the provider, because the providers that will be offering these benefits. And these providers are both public, private, and FBOs, faith-based. All churches or religious based facilities. So you need time to interrogate, to agree with them, to look at their cost structure, to look at your cost structure, because at the core of why the NHIF got into issues is actually also the issues of costing of services, and that is what has been been done more correctly now and transparently. That's why they are being published into paper, so that each person see this is the benefit I am entitled to, and this is the cost of that benefit, so that I am clear. I don't have to wonder, what am I signing into? Because the more we become transparent in a population that ideally have people who can read and understand, then it becomes better for them to also, look for social accountability and also ask for their entitlement within the package.
What needed to happen to go from where things currently are with NHIF and then move over? And that was supposed to have happened essentially on the 1st of July. And now we're being told it will now come to place on the 1st of October. What needs to happen in order for that transition to take place?
Yeah, so the things that are taking place, the wheel has not stopped rotating because the date have passed. We have said that the first entry point is registration. And in that registration, that's when one we start getting members enroll into the new system. The second thing that is important is the publication of the benefits. So, and when I talk about the benefits, it's largely the tariffs to the benefits because the benefits had already been published. So people would know what am I entitled for. What is coming out is the agreement of the tariffs for each of those benefits. So that is a process that ideally within 1 week or so will be done. The second thing that is paramount for the success of this financing architecture is actually the digital ecosystem. And in that digital ecosystem, one key thing that I want you to highlight, to understand, is that the biggest entry to fraud for the NHIF has been poor data that has been stored, where you find that, for instance, there is no single source of truth. So if I can be Daniel and can have another person's identity. Now, because of that, you find that you hear there are people, many cases of people who have been poorly identified. You find that Daniel was amputated on the leg, but when you come, I have the whole leg. So you find a lot of these challenges. Now, how do you deal with them? At the registration, there is linkage with the National Reference Bureau, where there is a registry that have kept your biometrics. So what we are doing is to just link you with your biometric. And therefore, you have one single source of truth instead of correcting fingerprints that ideally have been, polluted. So what we are doing is more verification so that we link the unique identification of each of the persons. Now, that is the first point where we want to say that we must identify a unique person who will be receiving their services, and therefore it is a person who will know that my, for instance, cover have been used today. And therefore, you also get issues of OTPs and the ability to identify. So that is registration. Then from there is the benefit. And then empowerment of facilities. In the past, we have had a lot of issues with choice of facilities. So you have to choose facilities to go and highlight, this is where I will be going. Now, where we are moving to is a very different environment altogether, where the Kenyan has power to choose to which facility to go. And when they go there, they know this is the facility I've gone. This is my card, which ideally will be your ID card anyway. And these are the benefits I'm entitled to. And this is the money that I will be paid for. Before you go, that information, you should have it. Now, this is a paradigm shift from what we have had. We have had a lot of darkness in what is covered and how it is covered.
No, Dr. Mwai.
Thank you.
Do you think people understand all these things you're saying?
Now, within the same time you have asked, people need to be explained things in a way they can understand. And I do believe that, I listen to you every morning. Sometimes I listen to what you are very right on some issues. On others, I see there is an informational gap between what we are talking about or what need to be done and what is outside here. Now, I think we must appreciate the fact that communication is important. And we expect that we will be able to do civic education more. We'll be able to explain to the citizens what is needed. And we also explain to them why it is important to have a social insurance for our country and not have, fragmented schemes that we have had over the period of time.
When will this happen? this civic education that you speak of, understanding by the public in terms of why it's important for social health to be a component of their daily expenditure. When will this happen?
So there is an elaborate communication plan that is finalized. And I want to say that the ministry is leading in this on engagement. And we expect that from next week, actually, this is part of it. I mean, if you so speak, we have already started. But from next week, we'll see more of education across all medias, channels of media that are available for communication, so that people understand. Away from many other, things that have been, been going on. One thing I want to highlight is that the health agenda has been crafted on solid principles that are globally acceptable. The technical teams have been on the works for quite some time. And therefore, sometimes technical things take long to be explained. But with a good elaborate plan on communication and educating, I'm sure that Kenyans are able to understand, because everybody can get sick. And therefore, it's a problem that is common for rich, poor communities, either employed or non-employed. So it's something that people are willing to engage.
Okay. I like what you're saying. And yes, some of these things are difficult to understand. And actually, I'm one of those Kenyans who has difficulties understanding what was so bad about NHIF that we had to create something absolutely new. I am still puzzled to date, because everything I've heard you say leads me to ask the question, okay, are we saying that everything that you are planning with SHA could not have been implemented under NHIF as just different aspects within NHIF, whether it's the critical care, whether it is the care that is being given at level 1 and 2, that these are things that could not have been provided for within the existing structure of NHIF? If we're talking about the data collection, are we saying that the data that was collected by NHIF was done in a manner that could not be upgraded, and that the systems that we speak of that are being implemented in SHA could not have been upgraded into NHIF? Is that what you're saying?
I am not saying that, because I started by saying that NHIF is an upgrade of NHIF, unless you are talking about retaining the word NHIF. So we begin.
Actually, it's not so much retaining.
Very good. Now I will take you there.
Yes.
In a minute. So when you look at the healthcare financing architecture, you have what we call, insurance-based systems. For instance, social health insurance. A social health insurance is when you pool together, all of you, and you pay differently. But that pooling should be driven by ability to pay. So you should not have poor people contributing a higher proportion than the rich, or vice versa, or the poor the sick. The sick many times are our senior citizens, are the ones who have many chronic illnesses. They are ideally not supposed to contribute more, despite the fact that they'll use less. Now, NHIF was somewhere in between. Social insurance, not social, not private insurance. It's there in between, because it was offering what we call managed schemes, 96 of them. All right. Now, when you have managed schemes...
What are those? Like teachers, police?
Yeah, you have a scheme. You have special group inside a whole scheme for everybody.
Okay.
So they are treated special inside the fund.
That's social.
So that makes it a little bit tricky, because when they are able to advocate for themselves better, they can come to this table. They can speak where I'm speaking from. But the other, because they are in the same scheme with everybody else who cannot come here because of their socioeconomic status, because they are in rural settings, because ideally they are not on boardrooms. The others tend to be oppressed. Now, what are we saying? We are saying that before the eyes of the good Lord, we are all the same. We are Kenyans. We can have an insurance that equalizes all of us, but also enable everybody to claim benefits from the pool, so that nobody say, I don't use. So the first thing I wanted to say is that we had managed schemes in NHIF. And those managed schemes became a very big problem because when you look at the expenditure was largely above the contribution for that cohort only inside a pool that have other monies for people.
So they were getting money from other contributors.
Fantastic. Number one.
Okay.
So mandatory scheme was not a good thing, needed to be removed. Number two, and more importantly, is the fact that for largely middle class, they were unable to claim. So you are employed, you contribute, and you have a complementary insurance.
Yeah.
Now, because of that complementary insurance, when you go to hospital, your complementary insurance is charged.
Yeah.
Therefore, you still continue contributing in NHIF, but you don't
use it.
Now, the paradigm shift is that there is no, by the time you get your complementary insurance, it will be above your social insurance. That means it's adding some more above what the social insurance is providing.
So the first charge will be now the NHIF.
Fantastic.
Okay.
And if you remember why the NHIF was taken to court, is because of that call. Because it would have killed private insurances. Now, the first charge in this time is social health insurance. And if I, for reasons that I have a complementary insurance, and I go to a higher level facility that is expensive, and I want to live nicely in there, my social insurance will still pay the tariff. So not say that deliveries is at 32,000 also, and because I've gone to a high facility, then my complementary insurance is charged. No, the social insurance will pay the entitlement, which is at 32. Okay. Then the complementary will peak after that.
The others.
Now, the other thing is that largely, a social insurance is a contributory mechanism. It's a pooling of by people. And then they do strategic purchasing. Now, when we move to strategic purchasing, is away from passive. We have largely been a passive purchaser. Passive is just buying for buying. Now, when you are strategic, you need to start understanding where is the largest burden centered. What should be the cost of that burden? How much money do I need to cater for the burden? And then you check, is it possible to get that amount? So that you put your mouth and your actions together. Now, we had a lot of promises that were never actualized. Now, away from NHIF, this is actually determined based on the cost of care that people require. So, the other thing that I wanted to highlight is that beside that shift, which is largely the upgrade of NHIF, there is a problem that we have had for a long time. Coverage of emergency services. When you are covering for emergency, I mean, I may not have paid for a social insurance, but I will not apply when my motorbike will be hit by a vehicle. I mean, I have no precision to when that will happen. Now, when it is tied to an insurance, then it is not right. So the Chronic Illness Fund, which has emergency as a separate key component, is new, and it is not a social insurance. It need to be housed within an architecture which is not a social insurance because it's exchequer funded. So what we are saying is that the same way when we mix oranges and apples, we'll have a problem. So the money is for emergency services. The package is defined. If you look at the regulations, and I really hope Kenyans take time when they are relaxing actually to look at the regulations and look at the benefits and the tariffs they are in for each of these components. And of course, the primary healthcare fund. People will not realize the importance of the primary healthcare fund until they remember that NHIF was not paying for services in lower level facilities. So, as you have mentioned, a clinic somewhere in Roysambu, taking services closer to the people. Now, that clinic would ideally be a level 2, either dispensary or health center in terms of level. Now, if we are not purchasing services from there, it is 1, unstrategic. 2, we will push people to go to level 4 and 5. For conditions they need not to go there because they can be seen closer to them.
So you're burdening the higher levels.
Correct.
And this fund then is saying that you can go to your local dispensary, local clinic.
Yes.
And you should get services there.
Yes.
But this will not be in the social health insurance.
It will be paid by the social health authority, but the money need to be kept separate in a way it is trackable to a person who is uniquely identified who seek those services. That's what we are
That's a
talking
structure.
about. But there is one new thing that I also want you to highlight to you. One of the reasons why people bypass healthcare facilities, they go very far. Number one in Kenya is lack of commodities. Because you have gone to a facility, it's public, it's private, it's FBO, it doesn't have the commodities you have. Ideally, the only option you have is either you go to another hospital.
Yeah.
You go start from consultation, you come down until you get the medicine. Already, a process you had done before that. Now, what we are saying is that it is possible to have community pharmacies. It is possible to have any outlet that is providing commodities to be able to give you those commodities which you have not gotten in that hospital, provided you have your card and they have been onboarded in line with the cost of the medicine.
So I can go to a facility, I get a prescription, and I walk out to a private pharmacy, which is on the list, and I can buy the medicine there.
Actually, you'll find your prescription there.
At the pharmacy?
Yes, because the digitization, these laws must be led for all of them together.
If you look at the comments, Dr. Hari, people are just like, The understanding is like, it's still very confusing. And you said that there's now a launch of a communication that comes to explain to people what exactly is happening. So let's start from here. Right now, today, is NHIF, if I went to hospital, am I using NHIF? And you've talked about registration. What is this registration? How is it happening?
Well,
and where?
Thank you. I think with the time, people will come to understand, because we desire to keep this in open. And I think that's why the ministry have really tried to, in terms of pushing information, but not as it should have done, because we are still in the cooking. So now is the time for implementation, as you say. So the first thing is that for one to register, there is a USS code that is 147 hash. That star 147 hash. This is one country and 47 counties.
Oh,
because all of us need to have the healthcare, and universal is for universal for all of us. You can also go to the SHA website, www.sha.go.ke. There's a portal, that one. You can also register there in the portal. You can also register in the previous NHIF offices. You can also do that.
What do you mean previous? They're still NHIF offices?
Yeah, NHIF is transitioning to SHA.
Okay.
So you can call them NHIF SHA.
Okay.
But ideally, the NHIF offices would still be SHA offices anyway.
Okay.
Again, we say it is an uplift. It's not. We are not saying that we are killing NHIF. It's an upgrade. When you upgrade, there are things you do. System retains some few things. Others, of course, it changes. So in the offices are ready for registration. You can do this registration actually at home, because if you have a phone and you can dial the USS code, the only thing that USS code do not help you do is actually get biometric.
Okay.
So for you to verify your biometric, remember, we have a single source of truth. When you put your ID, it will pull your biometric, but you need to say this biometric belong to Daniel. So you need to verify. So the verification is possible to do it within, facilities that are government. It's possible to do it within the Huduma centers. It's possible to do it within the NHIF SHA offices. And we are rolling out other devices that you'll be able to work with community health promoter to be able to verify your
come and verify
at home.
So even after doing the star 147 hash, I will still need to now do the physical biometric entry.
You need to verify your biometric.
Okay.
I'm just giving an example. When you take a private insurance, the first day you visit the facility
is when you do that.
You do that.
Okay.
Now, instead of waiting to get sick and go to facility to do it, we are providing avenues where citizens can be able to do this early, so that they don't get into problems when they want to seek care.
Okay.
And this initiative does not discriminate, And I talk this because much of the, middle class and unemployed people pay for premiums for their parents, for instance. Now, what we are saying now is that if they are, their parents need to seek care, they need to already be registered. There is a self-registration portal, and that's why it's enabling you to register from your home. If as we progress, it will become easier when you have what we are calling a client portal on your phone. You can monitor your health at your phone on your phone. So it's health at on your hand, so to speak, if I may put it like that.
So once I registered here,
yes.
Then what?
Now, when you register, two things will happen. You register if you are employed or if you are already in NHIF. Now, if you are already in NHIF, the system will triangulate your fingerprints. You'll use the single source of truth and the biometric that you are provided previously in the NHIF database. If they match, you need not do. It's an opt-in issue rather than biometric verification.
Okay.
But you'll find, and I can tell you this because it's a reality, that you might find that, I can see you have all your fingers. But when you match the NRB and the data that we have, it may not be clean. There's a lot of data there where, I might have 2 fingers or 8. But the other 3 belongs to another person. So the other 2 belongs to another person. Now, that is why people are asking, why the process of cleanup? Now, if we migrate this data without cross-checking with a single source of truth, and that's the knowledge I want people, the tweaking that I want people to see, that if I just correct information and I have no reference to a single source of truth, then there is no way of verifying whether that truth is truth. So I can have 3 fingers and yours, 2, and somebody else. That means I can already...
It can be 4 people at the same time.
Correct. And that means that I can build the fund, even if I am not the one who is sick. So that's the challenge. So people should understand it's a validation verification issue for the members who are already in the NHIF.
And is that currently going on as we speak? Because like you said, they're already members. So is that cleanup already happening as we speak in the back end?
Yes.
All right.
Yes. And we also thought it will take lesser time to actually match this than it has taken.
Okay.
But that work has been going on.
Painstaking.
So in this process, as all of this happens, what you then get your card at some point, or do you continue with your old card?
Before the launch, before the launch of services, because we have launched the process, and the process moves from registration. It's like cooking. You begin by boiling water, you bring flour, you add there until you cook your ugali. It is complete. Then you go to what is accompanying that ugali. Now, that's what we are talking about. We are now cooking registration. From registration, we go to access to services. But at the same time, onboarding the providers is happening. So by the time we are, it's better to say, give me some time to delay so that my ugali is well cooked before you eat. Rather than I tell you, because I said you'll eat at 1, then I serve you and cooked, not cooked that is not completely done. So
but
that's a kind of a problem.
But in the meantime, you still have access to health services under NHIF.
I was coming there. Fantastic. That's why it is an extension. So you still continue getting services with the NHIF until that time when we transition.
Okay.
So that we don't have disruption of services.
Okay.
That's the key main point.
Now, come October 1st, because this is the date that you've given us, unless you give us another date. But right now we're going with October 1st, right? I have a card, and I'm assuming that all of these processes have taken place. This verification that you speak of, the registration, collating everything that has happened, and then you move, right? Are we saying that I have a card now, and I can walk into a facility for the service? Of course, we know the 3 different funds under which one now you're going to access medical facility. You go, you present your card, you're treated, you come out, you do not pay a shilling. Is that what we're saying?
So, thank you very much. That's a good question. So, after these 2 things that will happen. One is that our expectation is that you'll use your ID card.
To do what?
As your card.
Your expectation.
That will be the SHA card.
Correct.
Okay.
There's not going to be
So-
a special card written SHA.
Correct. So,
Okay.
you know, people are in the business of having too many cards.
Buona, too many.
All right. So when you will go with your card, which happens to be your ID card. All right. And when you get to the facility will have been in the what we are calling the health registry, because you know that we have had quacks in the market. So now what we are doing is that the boards that are credit facilities have given us the list of facilities. We have created a provider registry. So when you go there, we know which level of care is provided there. So you need not to know whether you are getting from a PHC fund, whether it is NHIF, whether it is SHA, because the system will recognize you as a person who have come to seek service within a primary healthcare fund, for instance.
Okay.
Now you will access your services and you will pay, but you will pay from your social insurance or from what you are calling the social health authority. Yes.
I'm saying there is money that you have paid previously by the deductions. That one we know, right? I am saying physically, when I go with that card now to whatever facility at whatever level, and I present my card, I've been treated by doctor, get medicine, whatever, is there money that I am physically removing on that day?
No.
And paying? That's the thing.
You only need your card,
Okay.
which is your ID.
go facility, go home.
Correct. And that is why you need to be uniquely identified, because a card cannot uniquely identify you. You have to uniquely identify you is your biometric.
Okay.
So there's no need of coming with so many things, yet
Okay.
you have come yourself.
So you know, in Kenyan speak,
Yes.
it's free. I will walk to a primary healthcare facility for the primary healthcare fund will pay.
Yes.
So
That's why from
will
economics
walk
we don't believe in free things.
Me,
So
when I go to the facility, nitaitishwa pesa.
Free is I'm not paying any money at the facility.
correct. That's good.
Mimi situshi pesa
We teach you pesa. Because somebody else is paying.
because my taxes have already paid
Fantastic.
for the primary healthcare fund.
Correct.
Okay.
So we from as professions we discourage the use of free into the health things because people get free in a very different way. But I agree with what you are saying. It is you will not pay, you present your card and you will go home.
Naenda bure.
Yes.
Bila pesa.
Yes.
I have done the *147# as we were talking, and they've sent me a message. So you go through, put your ID number, your employment status, your marital status, are you living with disability, and then you accept that they are going to verify your information. Then they've given me a link here to go now to this link and you do what? It's a long process, boss.
Now, we must also accept that there's a process of getting into a good system. Now, the process of getting into a good system is getting good information in there. And when you take a private insurance, for instance, you fill a very big form. Why is it that we don't say that is big? There's no difference.
It's once.
The idea is that it is only once you provide the right information. And from there, the issue of fraud because of poor data being in the healthcare financing systems is removed. Is it because there is no other way
my
of
issue,
doing
Terry,
it?
I get it. My
Please.
issue is the multi-steps. You see, once somebody has done the *147#, right? There are many people who will believe that they are registered to SHA. But the expectation is that now the next step is you are supposed to either visit a SHA agent or you go to the website. There's that other expectation.
So
When you increase the steps, you're losing people on the way.
I agree completely with you on that. But there is a limitation on what a USSD can do.
True.
And, we must be very, open on what a jembe can do and how far it can plow and what a tractor can do. Now, we are saying that you need to have done your preliminary work. You have to have registered. When you go to the website, all that information have been pulled. You are not going to repeat. You are continuing because of the limitation of a USSD code.
Okay.
So if it was our prerogative, this is technology, is not even financing work, then it would have gone up to the end. But you need to go there so that you're also able to populate, including, ability to choose your dependents, to list them, to triangulate them, so that we know your unit. Who are we covering? So that's the process. But when you look at the SSD code, it is telling you where to go.
Yeah. It has just told me to the nearest agent. Now, that is a whole long story. So there's a lot of communication that's needed. Dear Eric, welcome to the Social Health Authority. Your application has been submitted successfully. Visit an authorized SHA agent or click the link below to complete your registration online using your application phone number.
Correct.
All right?
Yes.
So for somebody who does not then get to understand how to click the website and go, they're supposed to go to the authorized SHA agent. Are we going to see banners and clearly labeled places written authorized SHA agent, come register here, when this is going on?
So the work that I've started this week, Latif, largely, is actually to address the gap you are talking about. Because we want each and every person, each household in Kenya, to understand what am I supposed to do and where. Now, those SHA, designated registration areas,
Yes.
are clearly, outlined within the website, and they'll also be communicated. And you'll see this from this week going forward. It's an issue of driving people to a product that has been complete, because you have to wait to complete a product. Then if you went to that USSD and it's not working, then it would have become a very big issue. So I want you to look at this as phase one, which is registration. And registration you need to register, put in your document, your basic registration that pulls any other data that you have within the reference bureau, including your biometric.
Okay.
But when you get there, you have some few things to do. Among them is actually choosing your dependents. It's also verifying your biometric.
Okay.
Yes.
So the link takes me to the SHA website. The SHA website tells me register. It takes me to the eCitizen portal. That is, boss. How many
If I'm
people,
hearing you, you're saying the journey looks long.
It's just looking a bit long. This is a long journey, and you need to explain it in greater detail on how I'm moving there. That's just one feedback. But then the question is, how many people need to be onboarded by the time we are going live with service provision in October? Is there a minimum? Can you say that if SHA has not registered 1 million people in October, we extend NHIF again?
Two things. One is that registration is a continuous process. And to give you statistics is that you need at least from 30-40% of population to be in as you move to the future.
Yeah.
It's not difficult to actually get there, so to speak, with the value proposition being explained to the people.
Yeah.
For me, it's an issue of we have finished the architecture. What is remaining is breakdown and communication of the value proposition to the Kenyans, so that they are able to log. They were still joining NHIF anyway, and NHIF was a smaller, small and less benefit package, for instance, compared to this one. So it's an issue of communication going to the future.
Okay.
And this have just started. And it's good to provide. I'm technical. Technical people, I give you facts the way they are. What happens?
Communication people need to come.
Communication people takes it. I'm not a communicator.
Right.
I will not come here and say I'm the best knowing how do I push this message to my local village in Yaururu. I'll actually try, but most likely I'll fail. You could do better.
Okay.
So what the ministry is doing is to start bringing on board the communication expert, the people who are able to simplify. Because when I explain to you, even now, there are things I explain to you and you say them in a nicer way, I felt them lighter. That a normal Kenyan can understand, and I will do. Right.
Final question, Dr. Ari, as we close. Yesterday there was a story about what's happening with NHIF. With this extension, there appears to be some confusion. People who have chronic illnesses are going to facilities and they are not able to access their services because apparently there's some miscommunication on NHIF. Can NHIF continue paying for dialysis?
It is continuing to pay for dialysis, and SHA will also continue to pay for dialysis when it comes. So I want to people to understand that the basic principle is that we do not want disruption of services. And from where I look at it from, if you look at where does it pain more for Kenyans, is actually at chronic illness. And when you go to the principle of this fund, it is covering chronic illnesses in a bigger, far way than even expected, including things like organ transplant. And according to the process going into the future, is that the services will continue.
Okay.
Until when we roll out the new one.
Okay.
After rolling out the new one, we'll go to Canaan, which is better. Okay. But as of now, as we cook, we have to overlap. Otherwise, it's not a switch end. And
so we are still on this side of Jordan, but we are still accessing services.
Yeah, we are preparing
NHIF.
to cross. Yes.
Okay. Dr. thank you very much for joining us today. Dr. Daniel Mwai, the President's advisor on health financing, has been our guest talking about this transition to the Social Health Authority.
This is the Situation Room, the only way to start your day.